Well, know how refractory I am to the multiple choice questions. That is why I thought that I could do something different. And I would just start from the very bottom of my presentation. And without questions, we can discuss. I use some of these slides later on, at least, if you like. Discuss together what is indeed included into this nice review that is recently published in the JAMA. The three authors are Eddie Fan, Dan Brody, and Art Lasky. And we discussed a little bit about that yesterday in the masterclass concerning the case presentation. Well, if you look at this algorithm that is being proposed in that review, we can discuss together how to proceed. And if we all agree with this proposed algorithm, obviously I need your active participation and interaction. You may agree or disagree certain things. Let's first, one of the points that this algorithm proposes is the identification of the ARDS conditions. And one of the exclusion criteria should be the need of excluding any hydrostatic pulmonary edema correlated to the presence of heart failure. So my question to you, and it is what I do in my unit, because always asking myself and my collaborators how to do, how can you exclude? You remember that in the previous definition, there was the recommendation to use the wedge pressure, and we should stay below the magic number of 18 millimeters of mercury. Maybe all of you remember that. But this recommendation disappeared in the new definition. So my question to you, and I will tell you what I do, how can you exclude? Because you know that the patients are quite complicated at times and may have overlaps of various conditions. So we need to exclude that what we are doing, what we are seeing into the chest X-ray is not related to the heart failure. What do you do? Please. Something slightly different from the previous presentation, okay?
There is simple way. I mean, the history of the patient, if you have a cardiopathy, if you have a recent echo or we do an echo, BMP or pro-BMP, I think.
Okay.
It's quite...
So, you propose, for instance, to look at something that can come from the laboratory, pro-MBMP and the clinical history. Okay, this is one of the options, but if you should try to have something more quantitative, what you would like to use? Anybody else want to answer? Please.
Cardiac echo and PICO.
PICO, right. You know, one of the things that I believe is important in the new definition, that there is a sort of liberal proposal for using what we have at home. And this is very practical, because indeed we always have to think in mind and to keep in mind that when we propose definitions or recommendations, we as extensors of these guidelines or recommendations have to take the responsibility that this recommendation can be applicable everywhere. Also in countries with low and middle income. So we had to find out a way that is, let's say, as much as we can, universal. So the idea of using the PICO or the ECO can be a right one, as well as having the clinical the clinical assessment of the patient, looking, for example, if he has edema or in the limb or whatever it would be. So a very clinical approach. Do you agree?
No, well, yes, I do agree. Personally,
no, you can also disagree if you wish.
No. I agree that everything is what was said is correct. In our ICU, maybe we are still a little bit vintage, and we still love placing Swan-Ganz catheters. So
I love it because I do the same.
I guess we Swan-Ganz are about to be buried.
This
outside.
is an interesting issue. But you know that a Swan-Ganz catheter, it's not as popular as it used to be years ago. And so the fundamental question would be, how many of you should use the Swan-Ganz catheter just to determine if there is an implication of the heart for the generating the pulmonary edema? Would you please raise up your hands? So you see, it's still not very popular. I use both echocardiography, as well as the Swan-Ganz catheter. Yeah. But all my patients who are on RDS and are mechanical ventilated, they do have a Swan-Ganz catheter, always.
I agree also,
so
because
this is what I do. But
you get out of it much more than just wedge pressure, right?
Yes,
you get
of course.
all the issue of right ventricular pressures and cardiac output.
A number of good indicators that can help us for identifying the nature of the edema. So this is something that we can start with. Then, what about this is something that we can discuss. What about the bilateral chest radiograph opacities? Is that enough? What do you believe? You know that at times these patients may be quite severe.
Yeah.
They are admitted to the ICU. They are not easily movable, and so we try to rely upon the bedside taken chest X-ray with all the limitations. And please.
Yes, I've got an answer, but I still use the chest X-ray because
Okay.
I train people for chest X-ray analysis, but most of the limitation didn't focus of the technical aspect.
Right.
You can see when they just put on some X-ray just far away, but if you make a pause, if you do it properly, because the patient cannot be moved easily, you can have a lot of information also. So it's still possible to have a good quality and some answer with the chest X-ray. That's just my comment.
So this is an important point, what the colleagues are saying, that the interpretability of the same chest X-ray with different doctors and by using different techniques. At times, it's just sufficient using a weaker ray penetration for having an altered impression of the opacities. So we need to be very careful about the way in which the chest X-ray is performed, right?
6 kilo of tidal volume.
Yeah, but this is...
it decreased the quality of the chest X-ray.
This goes later on. We are still in an initial phase concerning the diagnosis and management.
Any other comments on chest X-ray? Yeah.
Yeah.
So perhaps you know the Kigali, so-called Kigali definition of ARDS, where PF is replaced by SpO2 and right Massimo and chest X-ray is replaced by ultrasound. Does anybody do that, replacing ultrasound with, chest X-ray
with ultrasound.
With ultrasound?
At times we use that. The problem is that the definition does not imply the use of the ultrasound, even though it can be very useful because you can see the densities and you can see the distribution of these densities all over the lung. You should do. The real problem that I see by using the ultrasound that still we do not have developed yet a clear-cut semi-quantitative methodology to be very systematic approaching the exploration of the lung. Yeah. And this should be done. This is a limitation that at times we do have still a quite huge operator subjectivity, you know, so you can interpret in a different way the similar picture. So how many of you do use the echo, chest echo?
Lung ultrasound?
So lung ultrasounds you prefer. It's more elegant
to
say lung.
No, just to ask you whether.
Okay. Well, But let's say that after that, you are quite convinced that your patient does have the ARDS, so you should start to treat them. And the first thing is that you have to be consistent with the recommendations of using PEEP. You can be surprised how often today the PEEP is not conventionally used in the diagnosis, and many of the ARDS are misdiagnosed. Do you use systematically, whatever would be the approach, invasive or non-invasive, at minimum of 5 centimeter of water PEEP? Do you? Would you please raise up your hand, all those who are in favor to use this approach? Is anybody that does not use the PEEP?
You mean as a first?
As first, because it helps for the diagnosis at least consistently to the burden definition.
Sure.
So, can we agree all together that placing at least 5 centimeter of water of PEEP is fundamental for the diagnosis? Yes? Okay. So, said that, we have to decide how to approach the patient. Because indeed, if you look at this algorithm that is proposed, depending upon the various severity of the patient, you may have several options. For instance, you can start with non-invasive ventilation. The algorithm says that when you identify patient with mild ARDS, which means having the PaO2-VO2 ratio something in between 200 and 300, with a PEEP or CPAP of at least 5 centimeters of water, then you are in a range where you can attempt a trial of non-invasive ventilation. My question to you, should you do that or not? Please.
Yes, we should do that.
Okay.
That's my answer.
We discussed already in the master class yesterday, you know.
Anybody who
Against.
would like to argue against non-invasive ventilation?
Feel free.
So I think non-invasive ventilation delays mechanical.
Aha. Well, you want to fight?
You want to fight with an Italian?
No, I understand your point. I can understand your point.
I don't believe that, but I'm just saying it for debate. Actually, I think we use much more NIV now, and we actually mechanically ventilate less.
Okay.
Yeah.
But it won't be just
So I think that your position is right, is a good concern, but we should start with some consideration. As first, we are speaking always about less severe patients. Even though Giacomo and the LungSafe have clearly demonstrated that the non-invasive and spontaneous breathing is widely used also in the most severe cases worldwide, which can be disputable or something not to do. Notwithstanding that, the recommendations and the guidelines says that should be focused exclusively on the milder patients. Well, said that, in my opinion, this is my view, but I would like just to know the opinion coming from the audience, the essence is to be very prudent and start with a very short trial. And if you are not sure, pretty sure that your patient is improving, not after days or many hours, but just 1 or 2 hours, or even less, then you shouldn't hesitate to intubate the patient. In this case, you may avoid any unnecessary postponement of the invasive ventilation. Well, said that, the other risk is to fall in love with the technique and continuing because you have a slight improvement. And so you want to insist and insist. But this is wrong because the risk of failure under these circumstances is very high. What do you think? What do you do? You try for how long, for instance? Or what do you look at?
For less severe patients, we'll try because we have a margin of time. I think the PaO2 to FiO2 ratio is still, more than 200. I think that in my practice, I have more time to decide with less severe patients.
Yeah, of course.
When it comes to moderate to severe, I think the attempt should be done for a short time, half an hour to 1 hour, to decide either to continue or to intubate the patient.
So, do all the others agree that if for milder patient we can insist a little bit more?
And is oxygenation, if I may stretch
Yes.
it a little bit, is oxygenation the main parameter you're looking at, or are there other numbers you would be looking at to decide?
I wanted to add something about
Yeah.
it, because it will depend, for me, it will depend also of the etiology. For example, a near drowning, it's completely different than completely a post-surgical, very complicated, multi-transfers patient like this, for example. And also, it will depend also of the clinical response, not only the oxygenation. If the patient should be really, really calm and without too much ventilation. So it's a little bit difficult clinical assessment, but it's much more clinical response and a quite cool ventilation without no too much effort.
Okay, I think that we have to admit also another point, which is not negligible. If you look at the situations that is present in many different countries, including mine, at times you do have a bed constraint, and you cannot admit your patients into the ICU. So you need to just take care of them in a way or another. And at times we are obliged to start a form of ventilatory assistance outside the ICU. There was an interesting abstract presented yesterday into the abstract section, where indeed this problem was pointed out here in Hong Kong, just ventilating patients outside the ICU, intubated and non-intubated. So it's something that we have to deal with. We cannot deny that this problem exists wherever you are, including my country or European countries. And so this can be at least an option, or a transient option.
Yeah. So just to follow up on the bright comment of our colleague, I think it's nice to, for example, if you look at the literature, there's this paper by Carto, I think is the first name, on critical care medicine that shows that one of the predictors of an IV failure, along with bad oxygenation, is high tidal volume.
High tidal volume, that's
so
right.
I think that this stresses the importance of that, not just looking at oxygenation, but looking at the ventilatory load overall is very interesting. And perhaps, Massimo, I mean, this is a little bit of an Italian job, but you might want to make a comment on whether some interfaces are better than other interfaces.
That's absolutely correct. You know, one of the problems is, on one hand, the recruitment, and the other is the transpulmonary pressure that we may generate when you keep the patient on spontaneous breathing. Well, not all the devices that deliver, the interfaces that deliver the non-invasive ventilation are equal. For example, one limitation that you may get is related to the use of the facial masks, where you have two disadvantages. One is that the objective impossibility of using higher level of PEEP for getting or achieving an improvement of the recruitment, simply because you increase the leaks. And just the mask fixation over the face cannot be so tight without any inconveniences like the skin breakdown, in order to reduce the number of leaks. And the leaks compensation present into the modalities that are available in the modern ventilators are not enough. And by the way, they do not resolve the problem of PEEP. There are other interfaces, and in Italy we love it, which is the helmet. You can see some examples into the booth outside the room, because it's a sort of hook that is placed over the head of the patient, and the patient is into a pressurized environment, and the leaks count a little bit less. There is also a continuous flow passing through. Then you can deliver higher level of PEEP. And in this case, achieving a better recruitment, maybe you can also have the opportunity to prolong a little bit the non-invasive ventilation more efficiently. So there are a number of issues, but we must confess that this kind of interface is very popular in our country and to some extent in UK, but not in all countries, and so cannot generalize. But if I may,
Sure. No, I just wanted to let you know
How-
that
how mu-
we still have 20 minutes, so just let you
how
know
many
how
minutes
to-
do I have now?
You have 20 minutes
Left?
left.
Okay,
yes. So just
fantastic.
to let you know.
Fantastic. No, this is absolutely true. So one of the, just finish up with the idea of the non-invasive ventilation, do you believe that it's quite reasonable what the algorithm suggests, telling that if the patient is stable, the PaO2, VO2 goes up to 100, tolerate non-invasive ventilation, to continue non-invasive ventilation up to the possibility of de-escalate this approach and then start, for example, the high-flow oxygen therapy or simple oxygen therapy, and then see if the patients go on. Do you believe that this suggestion is indeed reasonable? If there is a response, a reasonable response to continue? Yes or no? Oh, I see many people say yes. Okay, but then we are unlucky, our patient is unlucky, and then unfortunately deteriorates. And then we are obliged to start with the invasive ventilation, placing an endotracheal tube and setting up the ventilator. Oh, please.
Yeah, I've read these,
Yeah.
so I'm sure you're proud of me. But the one thing I was very surprised about is that there's no recommendation in terms of volume balance.
Yeah.
Because this group on the left, for example, so that is not an uncommon scenario for me to see. But along with, is the patient clinically stable, I always say to my fellows, what's the volume balance?
Okay.
And I
Very
think
good
that
point.
is something that really needs to be addressed, because I think if you don't address it, you're more likely to shift to the right.
Which is absolutely right, because we do not have concrete data exploring the amount of transpulmonary pressure when a patient is on non-invasive ventilation, then without an endotracheal tube, and instrumented these patients, for instance, with a esophageal catheter is very complicated. It's not like having a patient who is intubated or mildly sedated. Under these circumstances, it's very difficult to say what is the real transpulmonary pressure. However, what before Giacomo said can be important. If you see that the volume is very high, and indeed at times these patients have a very deep inspiratory swing, probably you may assume that the transpulmonary pressure, because of the increased negativity of the pleural pressure, may be quite high, and then you may generate a damage. So again, a good approach looking at this possibility is estimate or look at the volume that you have and then decide. However, as addendum, I have to say that if, for instance, you use another interface like the helmet, it's very difficult to really understand what is the real volume that you are delivering to the patient, because the volume that you read on the display of the mechanical ventilator, it's indeed the sum of the volume that you are delivering to the system and to the patient. And so what you get back is difficult to interpret. But by the way, the concern that you were mentioning, I think, is very important. But again, let's say that the patient is intubated, and then we have to start an invasive ventilation. Which are the recommendations? Control mechanical ventilation, target tidal volume 6 ml for kilogram per DT body weight. Look at the plateau pressure, should be below 30. Consider a PEEP in moderate or severe ARDS, higher PEEP, and then keep the PaO2 something in between 55 and 80 millimeter of water, or oxygen saturation 88 up to 95%, and pH 7.25 or below, above that. Do you agree? Can you, or do you believe that this can be a reasonable?
I would like to challenge the authors, because they got along too easily. saying consider higher PEEP in moderate and
Yeah.
severe. Higher than what? That's
Yes.
not, that's too easy to write. I mean, I'm joking, but that's higher PEEP. What's higher PEEP? So
Yeah.
I guess that's a statement where these guidelines are a little bit vague on. But
This is one of
perhaps
the
it's a
major
crucial-
issues. We do not know up to now which is the most reliable way to use to find out the best PEEP. You, coming from Milan, will answer that the best way is just to use the CT scan. Okay, no, you're critical.
Well, more Monza, you know.
Okay, sorry for that.
Cugini di campagna.
And so, what do you propose? You look at
We look at a mixture between compliance and oxygenation.
Okay.
This is what we would do. We don't choose tables, but if I may
Of
ask,
course.
how many of you use PEEP FiO2 tables routinely?
The
You know,
one of
like
the original
NIH
study from
or
the NIH.
other similar tables. That's very Italian, though.
I do the same. It's in our protocol, but very often.
And what the rest of you
But
do?
it doesn't necessarily mean that this is wrong. Wait a minute, because now we are understanding more and more. It is fashionable to say so, I understand, but this is a concrete matter in any field of the science to individualize the therapy. The patients are not all equal, and a recipe doesn't fit for all. So a size doesn't fit for all. We need to decide one by one and see how our patient responds.
How can we do that?
Please.
Thank you. Dr. Massimo, may I a little bit provocative for this?
Yes, of course.
No, I'm not fully agree for the tidal volume of 6 of P flat for below of 30, because if you look to the Lancet review of 2 years ago, we still use the lung protections, but the mortality of the area is still 40%.
Mm-hmm.
So is it possible that we add, let's say, for the driving pressure also? We have to take
Yes,
into
of
account.
course. Of
Because
course.
as long as we can maintain below of 80, forget for the tidal volume more than 6, forget for the P plateau more than 30, as long as we can maintain the driver pressure of 80. What do you think about that?
I wanted just to find out, let's say, see your slides. Just a second. Where is it? Yeah. Okay. You know all this slide because it's from the Marcelo Amato group. And what tells us? That probably, if we look at the driving pressure, we have to change slightly the mentality. We have always to keep in mind that what we have in front of us is the so-called healthy baby lung. And most of the variables we are looking at, including the compliance, refers a large part to this part of the lung. Well, so the change in mentality is moving from the tidal volume to the compliance-driven, or standard-driven, if you prefer, approach. And then if you look at the driving pressure, you may have a surrogate of the response of the patient to your volumes and to your PEEP. One of the major messages coming from, to my view, coming from this study is the fact that it is very important how the patients may respond to the variations of the volumes and the PEEP. Because if you see that varying one of these two variables, the driving pressure goes up, it is evident that something is going wrong. This is something that has to do with the overdistension and with the increase of the possibility to increase the VILI. If you see that increasing the PEEP the driving pressure remain the same, or at least diminish it, you are in a very safe condition. Well, so I totally agree that we have, as also mentioned Giacomo before, we have to put together several elements. Even though that algorithm that the ARDS, Lasky, and the other authors suggested, putting together these elements at the bedside may be very important. I can tell you what I do. I measure the compliance. I try to identify the inflection points, if any. At times they are not. I try to look at the response of the PEEP. I try to manipulate the ventilation in order, as I mentioned yesterday in the master class, take into account how the variables interact with each other. If you change the volume, you may change the plateau pressure. If you change the PEEP, you may change the plateau pressure. If you change the respiratory rate, you may change the plateau pressure. And we have always to keep in mind these interdependencies, because it is very important to adapt the volume, the respiratory rate, and the PEEP, keeping in mind reasonably to have a plateau pressure that is always below 30. This is my personal recommendation. As soon you should use the highest possible PEEP, taking in great consideration the level of the plateau pressure. Do you agree?
Totally.
Very reasonable, please.
Just one concern, if I may ask, how often you respect this plateau pressure to be lower or equal to 30?
We try as much as we can, always.
I
At
would
least
say-
in my unit.
Yeah, but how often it is possible? I
Uh,
think 30%
I
for
would
my
say-
side, the third of my patient, I
Okay,
have more than.
then we come to another point. What happens if just placing the patient on the magic 6 ml body weight and the best possible PEEP, the patient does not improve, or the plateau pressure goes up a lot? Well, in these cases, you have, in my opinion, several alternatives. As first, it depends on the patient. If the patient may be an obese one, for instance, my advice is, in these cases, try to use the esophageal catheter, because under these circumstances, maybe the PEEP level that you are using and the plateau pressure that you see are not the real ones. Because if you measure them taking into consideration the transpulmonary pressure and the real transpulmonary plateau, you may immediately realize that a good contribution to those pressures is given to the thoracic compliance instead of to the pulmonary one. And then you can be more liberal in increasing the PEEP, and you can see that you have a higher plateau pressure measured conventionally, but the real level of the plateau pressure, the transpulmonary plateau pressure, is much lower. And this is one possibility. The other point is that if the patient is a normal patient, why not to put the patient prone? This is another alternative. You have a too high plateau pressure, maybe the PaO2, VO2 does not go up as expected, then you put the patient prone. And you may see, in most of the cases, a great improvement, and it is not infrequent. This is not enough, then we can try some rescue therapies. Then someone may see that, may say that it's not adequate to use an O, because we do not have enough evidence. But as a matter of fact, most of us, time by time, use it because it's a sort of rescue therapy. It is not enough, well, then there is always the ECMO or the ECCOR. It depends on the patient. There are a number of studies, and there will be many more, demonstrated that the ECMO can be a good option in the most severe cases, provided the fact that you choose the right patients, you are quite careful in taking care of your patient, preventing the potential complications. And there are also situations where it may be sufficient to use the CO2 removal. You are skeptical.
No. I wasn't skeptical. I was just it just occurred to me as you were saying this that nice paper, I guess by Kavanagh and on the Blue Journal that was showing that literally many studies show that patients were put on ECMO before being put in prone position. So my question is, if this happens, it means that we do it, okay? Because us clinicians do that. No, not the cardiologist, nobody else. So why would we do that? Is anybody in favor of this choice, using ECMO before prone?
We can't do that in the UK. You cannot? No, because the UK have very restrictive ECMO practices. So we have a limited number of ECMO centres. And so if you refer to the ECMO centre, they'll almost certainly say, have you tried prone? So it's incredibly restrictive, but I think that's reflected in fairly good outcomes. And I think that's...
This is very interesting because it's very similar to what we do in Italy. What we try to achieve is just a quite uniform behavior in the various hospitals. We have created a national network that initially was created when we had the N1H1 pandemia, and now as an ECMO network, and now has been transformed in something else with the possibility of having a contact, a consultation, a telephonic consultation on how to set up the ventilator and how to manage the patient on site, and eventually centralizing the patient in the most experienced centers when this is needed. However, said that, it is true that at times we anticipate the real need of ECMO, underestimating the potential complications that we may get. On top of that, bleeding. Please do not forget that at times one of the major complications of ECMO may be an intracranial bleeding, for instance, and this is not negligible. This is described, and it occurs in some case series, even in 10% of the cases, which is a lot. So always keep in mind that it's not a trivial technique. However, I pointed out here in this slide, which is a list of reasons why the prone positioning that at times is disregarded because a bit too complex organizing the nurses in order to get it, may give some good benefit, because indeed, there will be a better distribution of the ventilation in the dependent lung region that are those in general more hidden by the, injured by the pathology. You have a reduction of the strain in the healthy baby lung. You unload the weight of the mediastinum and the heart that if you stay in a supine position, this is exerted on the portion of the lung which is anteriorly located. Then we have a better matching of the ventilation and perfusion. And you do have also a vascular recruitment that is due to the lower transpulmonary gradient. Then you have also a quite prompt reversal of the acute core pulmonale. So a number of advantages, and often we don't consider enough how beneficial may be put the patient prone.
So maybe, Massimo, we still have, I guess, 1 or 2 minutes. Maybe we want to wrap some take-home messages? Or
Yes.
I don't know how you want to finish.
Okay, I can show you what are, in my opinion, the potential clinical recommendations that I can give to you. This is obviously my view, but I think that the tutorial is also to be interpreted in this way. Try an if trial, but always you have to monitor the risk of failure, taking into consideration the class of the patients you are just treating. Set the tidal volume when you have a patient who is already on invasive ventilation, possibly below the 6 ml for predicted body weight, ideal body weight, with a driving pressure that ideally should be below 14. It is something that is very protective. 48 hours of paralysis, especially for those patients whose PaO2 and FiO2 is lower. prone positioning, again, for the same category of patients prevalently, but there is no real indication on that. Seems to be more effective for these patients who are more severe. High to moderate PEEP to severe patients, always maintaining the plateau pressure something in between 28 and 30. Avoid the routine recruitment maneuvers, because there are a number of concerning the recruitment maneuver, despite the fact that some may use it, especially when you don't paralyze your patient. And indeed, we need to be honest up to the end that the solid evidence that ECHO and ECMO may change the history of the disease is not clear enough. Thank you.
Thank you very much, Massimo. Thank you for this very clear final recommendation. And as last chairman, I have the privilege to close this very interesting session. So thank you to all the speakers and to all of you for the active participation. So have a good lunch now.